This is Sarah with registerednursern.com, and in this video I'm going to be going over myasthenia gravis. And this video is part of an NCLEX review series over the neuro system. And as always, at the end of this YouTube video you can access the free quiz that will test you on this condition. So let's get started. First, let's start out talking about what is myasthenia gravis. It is an autoimmune condition where the body attacks the muscle receptors that control voluntary muscles. And this is going to lead to muscle weakness. And anytime you think of this condition, think of muscles, specifically muscles that are becoming weak, and they're the voluntary ones that you can really control. So what type of muscles are going to be affected in this condition? Well, we have the muscles of the eyes, and this is usually the first sign that most patients have. They may notice that their eyelids start to droop. It can affect one eyelid or both, and they may notice that they start to have double vision, and this is where those muscles that control how your eyes align are becoming weak. So they may have what's known as the lazy eye, where one eye turns outward compared to the other one, which is straight, called strabismus. Another thing is that those muscles in the throat can become weak. And this is another common sign that a lot of patients have. They may notice that they have voice changes where their voice is a lot more hoarse, or they have difficulty swallowing, because swallowing uses a lot of muscles and these muscles are weak. So they're not swallowing properly, and they may notice that chewing is an effort. They cannot chew normally and they become really exhausted chewing. Those muscles just aren't doing the job. Along with other facial muscles, it can also extend to the arms and legs, and in severe cases, those muscles that we use for breathing and respiratory can fail. And we'll be talking about myasthenia crisis and cholinergic crisis a little bit later, and these muscles just aren't allowing them to breathe. So that can happen in severe cases. Now let's look and see what is happening in this condition. Let's look at the patho. Okay, first let's look at our key players. What structures are involved in this condition? Number one, we have the neuromuscular junction. And this is where, just like its name says, is where the neuron and the muscle fiber meet together, and where the neurotransmitter acetylcholine is going to be released. Now within that neuromuscular junction, we have some other important structures that play a role in this condition. One includes the nicotinic acetylcholine receptors, which are represented here in our purple, along with our muscle-specific kinase. This can also be affected in this condition, and its role is for helping maintain and build within this neuromuscular junction. But for this lecture, we're just really concentrating on these nicotinic receptors. Another key player, of course, is our acetylcholine, our neurotransmitter. And then we have the immune system to deal with, because it's the one that is producing these antibodies that are attacking these nicotinic receptors, along with our thymus gland. So to help us understand what is actually happening at this neuromuscular junction in myasthenia gravis, let's talk about what should normally happen. Okay, so this neuron, which is made up of cholinergic fibers, is going to receive an impulse. And whenever it receives an impulse, it's going to release acetylcholine, because we learned in our parasympathetic versus sympathetic nervous system video that cholinergic fibers release acetylcholine. And this acetylcholine, the neurotransmitter, is going to go down and bind with those nicotinic acetylcholine receptors, because remember, that's one of our key players. And whenever that happens, you're going to have muscle contraction. Also hanging out in here is a substance that I want you to remember, because it's going to play a role in our pharmacology part with how myasthenia gravis is treated. It's called acetylcholine esterase. Esterase, remember that from chemistry or anatomy and physiology. This is one of those enzymes, and it's going to break down acetylcholine. So it's going to break it down into two substances, so this process can keep taking place. So it's, in a sense, going to recycle the acetylcholine. However, let's talk about what's happening in myasthenia gravis. In myasthenia gravis, these patients, their immune system has built up antibodies against these nicotinic acetylcholine receptors. So they're not functioning like they should, and there's not a lot of them available. So think to yourself, if you don't have a lot of these receptors available, not a lot of this acetylcholine is going to get to those receptors. So those muscle fibers aren't going to contract like they should, so they're going to have weakness. Now, how does it tie in with acetylcholine esterase? Well, with the treatment for medications, a lot of times anti-acetylcholine esterase medications are prescribed to prevent this breakdown of acetylcholine from happening. So more acetylcholine will be readily available for those limited receptors and will increase the patient's muscle strength. And one of those that we're going to talk about is pyridostigmine. So how is the thymus gland involved in all of this? Well, first let's talk about where the thymus gland is located. It is located anteriorly in the upper part of the chest, behind the sternum, in between the lungs. And it plays a very important role in our immune system's health. It's the creator of T cells, which is super important for immune health by fighting viruses and bacteria. And in children, the thymus gland tends to be larger than an adult because remember, by puberty, the thymus gland has usually already produced the lifelong supply of T cells that we're going to need. But as the person ages, eventually to older age, this thymus gland will actually turn into like fatty tissue. Now, what they have found in people who have myasthenia gravis, the adults, their thymus gland is still enlarged. It's not small like it should be. And they have found that they have tumors, and a lot of these immune cells have congregated together in there. And it's thought that the thymus is actually erroneously creating these antibodies to attack these receptor sites at this neuromuscular junction area, which is causing the acetylcholine not to be able to get to those receptors to allow the muscle to contract. Now let's look at the signs and symptoms. What are you going to see in these patients that have this condition? One thing I want you to remember is one of these hallmark findings. Specifically, whenever you're talking to the patient, asking them their signs and symptoms, they're going to report that their muscle weakness tends to get weaker with activity, especially those repetitive activities, which makes sense based on the information we just learned about how that acetylcholine is attaching to those limited receptors that don't have the damage from the antibodies. So that just makes sense. They're chewing, keep contracting the muscle. There's just a limited amount of acetylcholine that can go to those limited amount of receptors. So the muscles are going to get weak. And when they actually rest the muscle, their muscle strengthness improves because they're not stimulating that muscle. So remember that. Okay, so to help us remember the signs and symptoms, let's remember the word weakness, because what do we have? We have weakness in this condition. Okay, W for weakness in the neck. Some patients, literally, if it gets so severe, they will have trouble holding up their own neck. Face and the arms and the legs. E for eyelid drooping. And like I said earlier, this can affect one eyelid or it can affect both. And this is going to tie into our next sign and symptom for A, appearance mask-like. And they're going to have like this very sleepy look to their face, and it's expressionless. They don't have any expression because the eyelids, especially if they're drooping on both sides, pulls the eyelids down, and their face muscles are so weak they can't really form proper expression, so they'll have this sleepy look to them. K for keep choking / gagging when eating. And what's this tied to? This is tied to those muscles that they use for swallowing. They're weak. They're not going to be able to do their job to help squeeze that food down. Sometimes the food can get into the lungs, so they're at risk for aspiration. N for no energy, and this ties back to they're exhausted because of the muscle weakness. So thinking from a nursing standpoint, if you were going to do activities, say a patient has a busy day, they have a lot of activities that you need to do with them that day, when's the best time to help a patient who has myasthenia gravis get those activities done? It would be in the morning time when they have got up from resting, from sleep, because they're going to have the most strength in their muscles compared to later in the day. Okay, another E for extraocular muscle involvement. These are the muscles of the eyes. They're going to be weak. They're not going to be able to hold the eyes aligned so you can see normally. They're going to have the lazy eye, which proper term is strabismus. And this is going to lead to them having double vision. So ask your patients, what do you see? Are you seeing double vision? S for slurred speech. Also, their voice can be hoarse or soft sounding, and that ties back to those weak muscles in the throat. And then our last S is shortness of breath. And that is because in really severe cases, just breathing, those muscles, we don't even think about it, but those muscles that we use to help us breathe in and breathe out just are not working in this condition, so they get really short of breath. Now let's look at our complications that a patient can experience in this condition. Okay, the first one I want to hit on is called myasthenic crisis. And in myasthenia gravis, know that this disease can go into remission where the patient's not going to have any signs and symptoms. But on the flip side, it can go into full-blown acute exacerbation where this disease comes on and they experience really severe symptoms that can lead to severe muscle weakness and eventually respiratory failure because these receptors are not receiving the acetylcholine like they should, so the muscles don't contract, and it can affect the respiratory system where they're going to need intubation and mechanical ventilation, so it can get really bad. Now, what would cause this? Okay, whenever we're talking about these two crises right here, I want you to remember the causes because that is where your lecture exams and NCLEX like to hit you on. Okay, so a cause of myasthenic crisis would be not receiving enough of their acetylcholine esterase medication. Okay, so remember, beginning of the lecture, I told you to remember acetylcholine esterase. That again was that enzyme that helped break down acetylcholine so it can be recycled and this process can keep happening. However, in myasthenia gravis, we want to prevent this breakdown of acetylcholine because we need all the acetylcholine we can get for these limited receptors so they can improve in their ability to make that muscle fiber contract. So the patient is under-medicated with their medication and they can go into this. Along with experiencing any type of stress, this can be physical stress or mental stress, like with surgery on the body. So remember, tell your patients, educate them on limiting their stress. Along with respiratory infections, they take a lot of work with the breathing whenever they get sick, and that's wearing those muscles out, and it can send them into this. So they need to avoid patients with or people with infection. Now let's flip it over to the other side and talk about the other crisis that could possibly happen in patients who have myasthenia gravis, and it's called cholinergic crisis. Now what can cause this? It's the opposite. It's receiving too much of this acetylcholine esterase medication. So you're giving them too much of this med. So what's happening? We're not recycling enough acetylcholine. So those nicotinic acetylcholine receptors are getting bombarded with all this acetylcholine, and it literally is wearing out that muscle fiber. And eventually what happens is that muscle fiber says, and those receptors say, I have had enough, I don't want any more, and we're not going to do our job. So they become weak. And so you're going to see severe muscle weakness and respiratory failure in this condition as well. So you're probably asking yourself, well, how can the physician know if the patient is in myasthenic crisis or cholinergic crisis? Because in the end, they have like the same signs and symptoms, which is going to lead to the diagnosing part. And that is where you want to be familiar with this as a nurse, where they can order what's called a Tensilon test, where Edrophonium, a medication, is given, and it will help the neurologist determine, is this myasthenic crisis or cholinergic crisis? So let's talk about Edrophonium. And again, this is a medication given during a Tensilon test. And it's used to diagnose myasthenia gravis. So say that a patient comes to them, they have unexplained muscle weakness where they can barely even breathe, they have difficulty swallowing, speaking, keeping their eyes open, and no one really knows what's going on, but they suspect that the patient might have this condition. So they can give this medication to them and see what happens. Also, it can help differentiate between the myasthenic and cholinergic crisis. So Edrophonium, what type of medication is it? It's an anti-choline esterase medication. So what it does is it prevents the breakdown of acetylcholine at that neuromuscular junction and makes more of it available at that site. So ask yourself, if we give Edrophonium to a patient and they have myasthenia gravis or myasthenic crisis, what is going to happen to their muscles? Are we going to have increased strength? Are they going to start to get better? Or are they actually going to get worse? They're going to get better. You're going to see within several minutes after this medication is administered that they are able to speak better, swallow better. Their eyes are going to open up more. Their respiratory effort is going to be a lot easier. You're going to see improvement of signs and symptoms. So remember that. Okay, what's going to happen if you give this medication to a patient who is in cholinergic crisis? Because remember, these two conditions, myasthenic crisis and cholinergic crisis, at first, the patients are going to have muscle weakness and respiratory failure. They're going to look the same. But what's going to happen whenever you give it to them with cholinergic crisis? They're actually going to get worse because you just gave them more of this anti-choline esterase medication, which is going to make more acetylcholine at those receptor sites, which they don't need any more acetylcholine. So they're going to get worse. They're actually going to have decreased muscle strength and more respiratory problems. So if that happens, you would want to give an antidote, and the antidote for Edrophonium, I would remember this, is atropine. Atropine is an anti-cholinergic, so it's going to reverse those signs and symptoms if they were in cholinergic crisis. So as a nurse, some nursing interventions you want to remember if you have to participate in one of these tests is before the test, you want to note what's going on with the patient. What are all their signs and symptoms? Then the medication was given. How fast did they improve, and what happened during their improvement. Now, if they are in myasthenia crisis or myasthenia gravis, their signs and symptoms will temporarily improve, but that gives the neurologist an idea what's going on and they can start treatment. So they will continue to have muscle weakness after this medicine wears off. Also, you want to have them on a cardiac monitor. Of course, have atropine ready to go if it needs to be given, and have the crash cart very close by in case an emergency arises with this. Okay, so now let's talk about some nursing interventions with myasthenia gravis, okay? So we know that the patient has muscle weakness from their face, their throat, their respiratory system, the muscles are not working. So one of the main things we have to watch as the nurse is that respiratory status. So we want to look at that effort of breathing, their respiratory rate. Ask them, how are you breathing? Is it difficulty to breathe? Watch how they're talking. Are they short of breath whenever they're talking to us? And you want to make sure that you have resuscitation equipment close by, suction, anything in case something like they have an acute exacerbation of this condition. Next, we want to watch their neuromuscular function. So during your head-to-toe assessment and throughout the day as you're caring for them, you want to check the status of their cranial nerves. And if you want to know how to assess cranial nerves, I have a head-to-toe nursing assessment video that you can watch, and I go over that in depth. So you're going to look at the weakness of those various nerves. Also, you want to assess their vision. Ask them, are you having double vision? And listen to the sound of their voice. Is their speech slurred? Is there hoarseness to their voice? And their facial appearance. Can they smile to you? Can they make facial expressions? And assessing that strength in their arms and legs. And you want to note their swallowing. This is important, especially for us, because we are giving medication. So how are they swallowing? And you want to know how they're swallowing before you're letting them eat and take medications. And that's where the speech pathologist will come into play. They will be consulted and they'll come evaluate the patient, see how they're swallowing. Are they at risk for aspiration, and recommend a diet or things like that for you to follow. And because they're at risk for aspiration when they're eating, you want that head of the bed to be greater than 30 degrees. And sometimes if they are having difficulty swallowing, it's just really bad, they may need a feeding tube, so you'll be maintaining that. Another thing from our standpoint is that they are at risk for falls. So they have safety issues. And why is that? Well, it's a lot of factors. Number one, if they have double vision, they're not going to be seeing very well, and you don't want them up walking without assistance. They can trip and fall. Plus, their legs and arms can be weak. They can be short of breath. Their oxygen saturations can decrease, and they can just pass out. So you definitely want to make sure that they're not getting up without assistance. Another thing is educating, specifically educating the patient about eating, because a lot of patients have difficulty with the chewing because their muscles are weak with that, and with swallowing. So there's some things they can do to help improve that function. So one thing is that it's best for them to consume small meals, so that requires less chewing, but to have larger meals, preferably in the morning when that muscle is the strongest, compared to later in the day, like for dinner time, to have smaller meals because those muscles are going to be really tired later on. Also, whenever they take their acetylcholine esterase medication, they'll want to take it about 30 minutes to an hour, which is the peak time of those medications before eating. So they have the most acetylcholine available at those receptor sites, so they can have a better time swallowing and chewing. Also, if they have difficulty swallowing, based on whatever the speech therapist has recommended, they can have thickened liquids like honey thick, nectar thick, and to take small bites, and to select food options that are soft. For instance, having soup rather than a fresh veggie tray with carrots and celery, which is a lot of chewing. It would be better to have a soup with maybe mashed potatoes, something that's soft that doesn't require a lot of the patient to chew. And again, just to reiterate, if you are going to be doing a lot of activities with the patient, or say the patient, this is a home health setting and they have a lot of activities they have to do, it's best to educate the patient to perform those activities in the morning when your muscles are the strongest rather than later in the day. Now let's take a look at the treatments and medications for this condition. And it's important to note that there is no cure for myasthenia gravis. However, medications can be prescribed and treatments to improve the patient's signs and symptoms and quality of life. Okay. Big medication used to treat this condition, of course, is the acetylcholine esterase medication. And one common one is called pyridostigmine. And like I said over here, whenever you are educating your patient or you are the one who's administering medications, try to schedule it with their meal times or the times that they're going to be doing something that requires a lot of effort during its peak time, which is about 30 minutes to an hour before meals. Now, again, with this drug, there's complications, and they could experience a myasthenic crisis if they were receiving not enough of the medication. So if they weren't receiving enough of it, but if they're receiving way too much of it, they're at risk for cholinergic crisis. And as a nurse, you just want to educate the patient about some signs and symptoms, maybe that they are going into cholinergic crisis, and things that you need to watch out for caring for this patient. So what are some signs and symptoms of a cholinergic crisis? They're similar to the overstimulation of that parasympathetic nervous system, and we talked in depth in that NCLEX review about that. So let's just recap. Remember, your parasympathetic nervous system is that rest and digest system. So its role is to help us digest food and reproduce and rest. So what's going to happen is this is going to be an overdrive because it's the opposite of the sympathetic system, which was that fight or flight system. So we're going to have pupil constriction, bronchoconstriction, increased salivation, and increased mucus production, which majorly puts them at risk for aspiration and respiratory problems. Also GI system, because it's being stimulated to digest food, cramping from the increased GI motility, and diarrhea, bladder incontinence, and bradycardia. And again, of course, they're going to have severe muscle weakness and respiratory failure from where literally the acetylcholine is just wearing out those receptors and the muscle fiber has had enough, so it's not working anymore. And some more medications that can be prescribed for this condition are corticosteroids, which would decrease the immune system's response, or even stronger medications that actually suppress the immune system. And of course, there are treatments for this, like surgical treatments, where they can go and remove the thymus gland with a thymectomy, and patients can have improvement of their signs and symptoms, but it's not a cure. Or in severe cases, they can have a treatment called plasmapheresis with administration of IV immunoglobulins, and this is where the blood is filtered and those antibodies that are attacking those nicotinic acetylcholine receptors are removed, and the patient may have temporary relief in their signs and symptoms. However, it only typically lasts for a couple weeks, several weeks to months. Okay, so that wraps up this lecture over myasthenia gravis. Thank you so much for watching. Don't forget to take the free quiz and to subscribe to our channel for more videos.